So good morning, everybody. I am Dr. Ashish Nabar from the Executive Committee of the present IHRS. I am the coordinator for this IHRS DNB Arrhythmia teaching program, and we have been doing it for last 3.5 years. And although say 2 into 12, that is 24 hours a year, is probably not sufficient for a cardiology postgraduate to know everything that probably he would like to know in arrhythmias and devices. But I think it's a fair start, which at least would let you benefit from the opinions and the explanations from the key opinion leaders in the country, but also probably stimulate you to read and not leave it to the end for your exams. So I think there is this kind of a dual approach, and the ECs, the previous as well as this executive committee of IHRS, has been absolutely supportive of this program, and that's how we have actually no dearth of people willing to run this program as a faculty, both as speakers and as moderators. So I think we haven't had any discontinuity in the program in the last 3.5 years, thanks to the faculty that's ever willing. We usually try to alternate between the EP study and ablation topics at one end and the CIDs or the implantable electrical devices alternately, so that everybody gets a fair idea of what's contemporary arrhythmia therapy. And that's how. So today I approached, or last month I approached Dr. Vanita Arora, who is the current vice president of the IHRS, to devise something contemporary in relation to the CIDs. And I'll let her introduce this program to her with the faculty. But you'll realize that it's completely contemporary and would be very helpful for your ensuing exit exams. I would only say two things. We have very good moderators for this program today, Dr. Haigreev Rao from KIMS, Hyderabad. Whenever things try to go a bit too intricate for a DM postgraduate, I am sure Haigreev will instill immediately a lot of clinical sense in the discussion, and that's why I have him here. And Vanita is also keen that Haigreev does his bit. Uh, but at the same time, I have Dr. Neeraj Yadav, who is extremely good at reading the electrograms from these devices, which is also probably gets somewhat sidelined in the postgraduate training, and not necessarily everywhere, but that's where Neeraj comes in, and he will help us to decipher some of the nitty-gritties of the procedure and the reading of the electrograms. For some of you who cannot attend this program, previously Dr. Vanita Arora as a secretary and now Dr. Rakesh Yadav as the secretary of the IHRS take all the pains to put this program on the website. And this website can be visited by everybody and you don't have to log in. So it's much before that. And therefore, everybody and anybody can review some of the past programs, including this one, which are regularly uploaded on the website. So I don't think I need to stand much between you and the learning and Vanita's team. I'll let Dr. Arora take over and explain what her concept was when she devised this program and the faculty for this program. It's really from all over India, so I call it a pan-India program. Vanita, floor is yours.
Thank you, Ashish, for the kind introduction and starting the session with a very positive bang, I should say. So the conceptualization of the program was pretty much done in consensus with Dr. Haigreev Rao, and looking into the importance of what is as of today DNB students requirement for CIED. The technology, the concept, the way things are done are very different from the previous scenario. I mean, I would say even 10 years ago, we never used to do pacing or do the programming of these devices in the way we are doing it now. So I am extremely happy to have been able to get together with all these stalwarts from all over India to conceptualize and be here today. And thank you so much for that. Thank you, Sushanmuga. Thank you, Kush. Thank you, Suchit, for agreeing to do that. And my special thanks to both Haigreev and Neeraj for accepting to coordinate this program, because they both are brilliant, for that. So I think let's start with Dr. Shanmunga. Shanmunga is a wonderful friend and a extremely good electrophysiologist because he has put the conduction system pacing not only on the Indian platform, but he has put India on the international platform with his good work and his writing. So I'm very proud of him. I'm really proud of him. And so we designed the conductions. Whenever conduction system pacing comes to our mind, SS is the first name that comes to the mind. And the other concept of pacing is leadless pacemaker. I happen to be doing a lot of leadless pacemakers, so I have taken the initiative to talk about that. Uh, Another concept which came in picture is the multi-site pacing in the CRT. So, what is the status of this multi-site pacing today? When you say multi-site, what it is actually there? What are we planning to do? Because CRT, whatever said and done, 30% are still non-responders despite our best efforts. So, Suchit will be talking on that. And Kush, my very dear friend, another one, Kush, will be talking on the remote monitoring because during COVID, we have learned that a patient actually doesn't have to be present in the clinic to be analyzed for for the programming, and remote monitoring has taken a huge step in the management of heart failure patients, especially. So, with these words, I think I give the stage over to Highgrave and Neeraj to initiate the session, please. Thank you. Highgrave, you there?
Hello. Yeah.
Highgrave, you there? Highgrave is not here. So, Neeraj,
Hello.
are you here?
Yeah. So,
Why don't you start?
yeah, so we'll start with the first talk by Dr. Shanmuga. So, a lot of insights of left bundle branch pacing that we do comes from the work of Dr. Shanmuga Sundaram. So, he's the best person to conduct this talk on CRT versus left bundle branch area pacing in heart failure patients. And I'm sure he will simplify this concept to all the students and residents. Uh, Dr. Shunmuga, you can take over and start the talk.
Thank you, Neeraj, and thank you, Ashish sir, for giving me another opportunity in this forum. Let me start the topic. I'll share this. Slides are visible?
Yes, Shanmuga. Slides are visible. You are audible. You can start.
So my job is to discuss about the differences and advantages of biventricular pacing versus left bundle branch pacing for patients with heart failure. So let me start with a case scenario. A 56 years old gentleman who had undergone IHRS valve replacement in 2020, presented with left bundle branch block, white QRS, severe LV systolic dysfunction with an EF of around 25%. His coronaries were normal. He had recurrent episodes of heart failure hospitalizations despite DDMT for more than 3 months. This is ECG. As you can see, the ECG is showing a complete left bundle branch block, which fits into Strauss criteria. As you can appreciate, the multiple notches on the inferior and lateral leads. And this is how this LV was getting activated when we do the activation mapping. The concept of left bundle branch block is, since the left bundle is not getting conducted into the left ventricle, so it will be indirectly activated from the right bundle through the interventricular septum. So ultimately, as you can see that activation wavefront, the lateral wall of the left ventricle will be the last site to get activated. So this will produce a desynchronous activation of the ventricle. So when the septum contracts, the lateral wall will be relaxing. And when the lateral wall contracts, the septum will be relaxing. So this movement will ultimately result in LV dilatation, LV dysfunction, and recurrent heart failure hospitalizations. So these are all the treatment options which currently we have, gold standard biventricular pacing, and the novel concept of his bundle pacing, or left bundle branch pacing, which can be done with a dual chamber pacemaker, or with an ICD, or with a CRT, or even with the CRTD pulse generator. So this, among these different options, we may have to choose one of the best and cost-effective therapy for this patient. So we know that biventricular pacing is the gold standard treatment for any patient with YQRS and LV dysfunction. This being in the practice for more than 3 decades, and we have shown excellent mortality and morbidity benefit, though at least 1/3 of these patients will be a non-responders. You can see at least 2 to 10% of the patients having lead-related issues, poor venous anatomy, the major cause for the procedural failure, sometimes high thresholds requiring frequent gen changes, and chronic nerve capture resulting in procedural failures. So this problem has been overcome by what is called as a conduction system pacing. So we all talk about conduction system pacing being an alternative for resynchronization therapy. So what is the actual concept behind using conduction system pacing for cardiac resynchronization therapy? So we know that the fibers inside the His bundle are longitudinally dissociated, and some of the fibers will be predestined to enter into the left bundle, and some will be predestined to enter into the right bundle. So if you have any segmental disease, for example, if a disease is affecting particularly the red fibers, the patient will have left bundle branch block despite having an intra-Hisian disease. Or if it affects the yellow fibers, the patient will have right bundle branch block despite having an intra-Hisian disease. So how is it going to work? We're going to deploy the lead by mapping the His bundle distal to the site of disease, or conveniently in the proximal left bundle, where in majority of the patients it will be disease free. So let me show an example. So this is a 60 years old lady with the left bundle branch morphology in the surface ECG. As you can see, a typical LPBP, wide QRS 160 milliseconds. And this patient, we did a quick EP study before the procedure to see how bad is the His bundle. So as we have discussed in the previous slide, majority of the patients with a baseline LVBP, they will have an intra-Hisian disease. So this will be reflected in the intracardiac electrograms by the prolonged HV interval. You can see here, this is the temporary His catheter placed from the groin, and it recorded an HV interval of 88 milliseconds. We know the normal HV interval, it is between 35 to 55 milliseconds. Anything more than 55, we call it as an abnormal HV or an intra-Hisian or infra-Hisian disease. So this particular patient had a prolonged HV, suggesting a possibility of either an intra-Hisian or an infra-Hisian disease. So the next step, we took a 3830 lead and mapped the His bundle. At one particular point on the distal end of the His bundle, we got a beautiful HV of 40 milliseconds, suggesting that this is a disease-free zone, and we have bypassed the disease segment of His bundle. And this confirms that this particular patient had an intra-Hisian disease producing left bundle branch block. So once the lead is deployed, you can see a beautiful normalization of the QRS with T-wave memory. And needless to say, once you resynchronize the ventricle by providing a perfect conduction system pacing, they will have a near normalization of the LV at the end of 3 to 6 months. So being an intra-Hisian disease, it may be difficult for majority of the people to identify the disease-free segment, but Wang has suggested an easy strategy where the lead can be deployed directly over the proximal broad fan of left bundle fibers. So as we understand from the previous electrophysiology study that almost 95% of the patients with a left bundle branch block morphology have their disease restricted to the His bundle, meaning that, so if you are taking any random patient with a non-ischemic cardiomyopathy and left bundle branch block, there is a 95% chance that you will be able to correct the QRS by deploying the lead in the proximal left bundle. So this is what we have demonstrated. So once you correct the QRS with a single left bundle branch pacing lead, you can even skip putting the CS lead for a cost or providing a cost-effective CRT. So what is the need for providing using the conduction system pacing? This is because it provides a much physiological activation of the ventricle as opposed to the biventricular pacing where there will be a myocardial or epicardial pacing. It provides superior electrical and mechanical resynchronization. We can see in the cartoon, the lead is deployed in the left bundle and the activation map showing how quickly the left ventricle is activated and how quickly the lateral wall of the left ventricle is getting activated in synchronous with the septal wall of the left ventricle. So this provides superior electrical and mechanical resynchronization. And as I explained in the previous slide, you are given an option, you will be given an option of using a dual chamber pacemaker for providing a CRT, which is much important in a country like India, where financial constraints are a big issue in achieving the proper therapy. And as you can see in the previous ECGs, the ECGs will be much cosmetically better as compared to an RV-based or a biventricular-based ECG. Even the functional mitral regurgitation tends to respond as early as 10 days because of superior electrical and mechanical resynchronization. So trials on IV pacing have shown that the reduction in the functional MR severity varies between 30 to 45%. But in one of our study, we have shown nearly 80% of the patients had their functional mitral regurgitation getting reduced in a span of 1 to 2 months, even before the left ventricle had normalization of the LV function. CRT for kids, there is not much option for providing CRT for kids because of the small venous size and bulky devices. So, but with the advent of conduction system pacing, the leads being a small lead, we can still provide a resynchronization therapy with a single lead, or in some cases, with a dual chamber pacemaker to provide a much superior response as compared to a biventricular pacing. Having said that, since we are dealing with a novel therapy, we need to have a scientific evidence before it can be widely practiced. So what are the current scientific data available to show that the left bundle branch pacing is either good or better than biventricular pacing for heart failure patients? These are the early randomized studies which are published in 2022. So both these studies have shown that the left bundle branch pacing is either non-inferior or in fact superior as compared to biventricular pacing in providing resynchronization therapy, though the numbers involved in both the trials were really small. So this is one of the largest non-randomized comparative data which compared the patients who had undergone biventricular pacing versus left bundle branch pacing. So in this study, clearly it has been demonstrated that the biventricular pacing is a little inferior as compared to left bundle branch pacing in terms of reducing the occurrence of death or heart failure hospitalization. Not only in patients with the baseline LV morphology, but also in patients with a wide QRS, irrespective of the underlying morphology. It provides superior electrical resynchronization in terms of reducing the QRS duration and superior clinical response in terms of improvement in NYHA functional class. Now we have a lot of trials available, both randomized and non-randomized. So obviously we can expect a lot of meta-analysis to come. This is one of the meta-analysis which was published in Arrhythmia just in the December 2023. They have compared nearly 8 trials which have compared the left bundle branch pacing versus biventricular pacing. As you can see, being a quick procedure, once you have crossed 30-40 cases, which requires a learning curve, then the procedure duration will be much less as compared to a IV pacing. The fluoroscopy time will be less. Hardly the mean fluoroscopy time for deploying the left bundle lead will be somewhere between 5 to 7 minutes. The pacing threshold, we know the left bundle is going to provide a better pacing threshold as compared to the CS lead, and we don't have to worry about the phrenic nerve capture. We don't have to worry about the poor venous anatomy. And the follow-up pacing threshold, we know that at least 2 to 5% of the patient can have rising threshold with the CS lead. But when it comes to the left bundle branch pacing, at least we have 5 years follow-up, which says that the rising threshold by more than 1 volt is very less. So in terms of the electrical response, we know the left bundle branch pacing is going to produce a cosmetically better in ECG in terms of reducing the QRS duration, a better left ventricle in terms of reducing the dimension, and a better clinical response in terms of reducing the mortality and heart failure hospitalization. So overall, when all the trials were compared, the left bundle branch pacing was much better in terms of improvement in LVEF and echocardiographic response. So this clearly suggests that though majority of this data comes from a non-randomized trial, but it clearly suggests that the left bundle branch has a bright future. So when it comes in terms of a randomized trial, which is currently going on, definitely left bundle is going to produce a superior response. So ultimately, probably in the near future, is going to get a class 1 recommendation. Having said that, not all left bundle branch block or not all white QRS can be corrected by doing a left bundle branch pacing alone. So we may have to go for an additional coronary sinus sleeve. So how to decide? So this is our protocol. Just see whether you are going to get a good left bundle branch capture or not. I'm not going to discuss about the capture criteria for left bundle, but to put it in a simple terminology, you need to have a QR pattern in lead V1, which confirms that you are in the left bundle area, along with short and constant R wave peak time when you pace at high and low output. So if you're going to get a good left bundle branch capture, then measure the R wave peak time. So if the R wave peak time is less than 90 milliseconds, so that means that within 90 milliseconds, your LV lateral wall is going to get activated. So that is fair enough to accept this and give a dual chamber pacemaker. On the other hand, if the R wave peak time is more than 100 milliseconds, that means that either the left ventricle will be too big, or there is a lot of interstitial fibrosis which is producing slow conduction, or there is a distal uncorrected disease, probably distal to the site of the pacing lead, and you may have to go for an additional CS lead to make it as a LOD CRT. And even this LOD CRT has been shown that the results are much, much better as compared to a conventional bi-week pacing. So it's our general practice to attempt left bundle branch pacing first and look for the pacing parameters and then decide whether we are going to add a CS lead or not. So even in patients who had a failed biventricular pacing, either because of poor venous anatomy or late rising threshold, this left bundle branch pacing can be done as a rescue procedure to produce superior results. But how to choose between CSP and CRT? It's a $1 million question. It's not a straightforward answer that for X patient you have to go for CSP and for that Y patient you have to go for a CRT by week basis. Rather, you have to tailor the therapy for all cardiomyopathy patients. So identify the scar. So that is our ultimate goal. Identify the scar, quantify the scar. Just look, we see where the scar is distributed, risk categorize the patient, then decide about the modality of the treatment. For example, so this is a short axis view of the left ventricle in a cardiac MRI where it was taken after giving a gadolinium. You can see a white structure on the anterior septum, superior aspect. And this is the area where usually we'll deploy the left bundle lead. So this side, if it is scar-free, you can see this is the post-procedural CT image showing the left bundle lead. So if you are going to see this segment scar-free, if this segment is scar-free, then probably left bundle branch can be considered as a first strategy. On the other hand, if you see this segment is completely scarred, so this can happen with any patient with anterior wall MI, QRBP, white QRS, severe LV dysfunction, your septum will be totally scarred. So in these patients, probably left bundle branch pacing is not going to give any good results, so you may have to go for a conventional bi-week. On the other hand, if you see a scar in this lateral wall, so this is corresponding to the LCX territory. So this is the infralateral wall and this is the anterolateral wall. So if you see a scar in this territory, so we know the CS lead, the so-called LV lead is going to land over this area. So if there is a scar, definitely the CS lead will not give a better threshold. So even if it is going to capture, it produces a bizarre QRS, and pacing over the scar put the patient at risk of ventricular arrhythmias. So definitely these particular patients, it's better to avoid CS lead and go for a conventional left bundle branch pacing. So identify the scar, quantify the scar, study the distribution of the scar, then decide about the modality of the treatment. So that's what we did in our study. So we risk categorize the patients with a non-ischemic cardiomyopathy into low-risk group and high-risk group. So in low-risk group, we provided only left bundle branch pacing. In high-risk group, we provided both left bundle branch pacing along with an ICD. We can see almost 96% of the patient left bundle branch provides a superior electrical desynchronization in terms of reduction in QRS duration and improvement in LV content. And based on the scar, you can see those patients with a low scar burden, the death, heart failure, hospitalization, arrhythmias are much, much less as compared to those with a high scar burden. Similarly, the normalization of the LVEF was 80%. So this can never happen with a conventional biventricular pacing at the end of 12 months. You can see at the end of 12 months, nearly 80% of the patient had normalization of the LV function with a left bundle branch pacing alone in patients with a low scar burden. And this is a big thing for a country like India, where financial constraints are a big issue in providing an optimal therapy. So this is our way of dealing the patient. Start the patient with 3 months of guideline-directed medical therapy, categorize the patient into low-risk group and high-risk group based on a cardiac MRI. In patients with the ischemic cardiomyopathy and a septal scar, the ideal way is to go for a biventricular based CRTD therapy. And in patients with a non-septal scar, if you see the septum is still free of scar, probably to go for a leber branch pacing. And if it completely corrects, we can go for a lot ICD where we'll be putting the ICD lead, DF1 ICD lead, and an additional leber branch pacing lead, or even a leber branch pacing. Even the ICD lead can be directly deployed in the leber branch area, what we call it as a leber branch area pacing defibrillator. On the other hand, if there is an incomplete correction, we may have to convert it into a LOT CRTD. The similar protocol works here in non-ischemic cardiomyopathy with low scar burden. So only leber branch pacing. It can be either a dual chamber or a triple chamber. If there is a high scar burden, then probably you may have to go for a LOT ICD or leber branch area defibrillator if it is a complete correction, or a LOT CRTD if there is an incomplete correction. So in patients with in patients with an ICD indication and without a septal scar, there is a possibility of deploying the ICD lead directly in the leber area. So this is going to reduce the number of leads spanning across the tricuspid leaflet. We know larger the number of leads, the larger the indication, the higher the indication incidence of tricuspid regurgitation, and higher the chance of lead-to-lead interaction. We had a case report of LBVP lead getting fractured because of interaction with the ICD lead. So when you want to reduce the number of leads with the septum is scar-free, probably you can attempt putting this leber branch ICD lead in the leber branch area, but this still it is in the experimental stage. Is one of our study with a short follow-up of 4 months have shown that procedural success rate is good, and all patients had undergone DFT testing and showed that the lead could successfully sense the arrhythmia and provide optimal defibrillations. So coming back to our patient, as cardiac MRI showed no scar, and the RV peak time after doing leber branch pacing was 82 milliseconds, which is still under our cutoff of 90 milliseconds. So we could see a complete correction of LBBB. We provided a dual chamber pacemaker, and you can see the reconstructed CT image, the aortic valve, the non-coronary cusp, and the left bundle lead sitting just below the non-coronary cusp. Needless to say, once you have a good correction of QRS, definitely the patient will have a normalization of the LV function. The natural history will decide when is going to get the recovery of the LV function. If it is in the early part of the natural history, the recovery will be quite early, within 3 to 6 months. On the other hand, if he is in the later part of the natural history, with the dilated ventricle, it may take at least 1 or 2 years to have a normalization. So just to summarize the difference between biventricular pacing and conduction system pacing, it's flooded with evidence, but conduction system pacing has only 5 years of experience. So by the class 1 indication, it is class 2 or class 2B for CSP as of now. There it is a non-physiological activation of the myocardium and epicardium. Here it is a physiological activation. The non-responder rate is close to 30%. Here as if there is no direct data, but it's our experience for a non-ischemic cardiomyopathy, it's somewhere around 5%. The non-LB morphology, we know the suboptimal response with BIV, but we have shown that in patients with a right middle branch block and even in IVCD, the LOT CRT will provide better responses compared to biventricular pacing. The functional MR, super responders, QRS duration, arrhythmic risk benefit, so everything is better with the conduction system pacing as compared to biventricular pacing. And for us, practicing in a center where the patient can't afford for a CRTP or a CRTD, we can comfortably do a dual chamber pacemaker for majority of the patients with a non-ischemic cardiomyopathy and LVVP. And it's not nevertheless important to say that even in pediatric population, the conduction system pacing works well when it comes in terms of providing a CRT. Thank you very much for your patient listening. Thank you.
Shanmuga, that is, thank you very much for a lovely presentation that you are known for. Now, before there is one question in chat box, and there will be some more questions. Before that, because it's a DNB program, I would like to first spend a minute or two putting Shanmuga's research and his talk in the right perspective, so that they understand we go from the known to unknown. The first thing is, I would like to say that heart failure is a major problem where medical management with the guideline medical director therapy is the first step to be used, at least for 3 months before considering a device. Second thing is, historically, we had 2 subsets of patients with heart failure. One with a left bundle branch block, second, a right bundle branch block, and non-specific intraventricular conduction disturbance. Now, even among the left bundle branch block, we had a subset which was 120 to 150, 150 or more, less than 120. Now, clearly, over the years, data has demonstrated that it is patients with 150 milliseconds or more with left bundle branch block who derive the maximum benefit or optimal benefit with CRT. CRT involved the putting of a right atrial lead, right ventricular lead, and a CS lead. Now, the problems with that were, apart from the classical non-responders also in expert hands, the other issues with CRT were non-availability of optimal veins. Now, it's very important for CRT that you need to have a posterolateral vein, which will face the lateral wall of the LV, that is the circumflex territory, and pre-excite that. In significant number of patients, we have veins, but we don't have a proper vein going there. The size is small, the distribution is small, or then some of the veins in unintended or unreally educated operators, they go into the anterior interventricular vein, producing a worse outcomes with CRT than. So in these situations, what was the options for us? For us, the option was to put a RA-RV lead and send the patient for a epicardial surgical lead. This was the classical thing if you really wanted to help the patient. Or, you know, some of the patients would go just with a wide QRS, not achieving this one. Now, herein came in the Shanmuga's research and left bundle pacing, where it obviated the need for cardiac surgery, where in case you could not find the veins, you could not do any of these things, you could still put a left bundle lead. The second category of patients are the patients who had pacing-induced cardiomyopathy, patients who had pacemakers and developed LV dysfunction. So the QRS became wide because RV pacing produced wide QRS. And this again was the classical situation where a left bundle pacing helped patients with this. Now, having said this, so whenever you have a new tool, new technology, we must use it in the right perspective. It is not that it is going to wash off the old technology. Shanmuga's last slide is very informative, very important. Please focus on that. CRT is a proven therapy. We have bundles of data and long years of experience. And second thing is he's comparing a CRT as a, real world experience of CRT data with left bundle pacing, which is used by very, very few experts like Shanmuga and the likes of them in the world. So the data has to be seen in that light, that this CRT versus left bundle, it is not a real world versus real world. Actually, it is experts versus real world. So left bundle has a real role. One point which I would like him to say is the two other parts, right bundle branch block and the interventricular conduction disturbance, where the CRT had absolutely no role. Dr. Shanmuga, is there any data in these two subsets?
Yes, sir. The right bundle branch block, we had a subset of 120 patients, which was this was published a couple of years back, again from the multi-center study. We could still show that left bundle branch pacing produced significant reduction in the QRS duration and improvement in LV function from 33 to 44 milliseconds. The concept is in majority of the patients with an underlying right bundle branch block, there may be an associated musculating left bundle branch block. So if we can carefully see the ECG, we can see the monophasic R in lead 1 and V6. And with the help of the lead completely traversing the septum, with the help of the anode, when you do a biculture of both cathode and anode, you'll be able to mask this RVV delay pattern and produce simultaneous capture of both sides of the septum to produce a synchronized activation of the ventricle. And the third concept is again retrograde conduction entering into the this bundle and antegrade activation via the this bundle, via the right bundle. So it's all the three important mechanisms by which conduction system pacing is going to help in patients with right bundle branch block and LV dysfunction. And in majority of the patients with the IVCD, the LOD CRT works much better. So that is the data from Huai Hospital Group, where they have shown that LOD CRT, they compared the subset of LOD CRT with the biventricular pacing for patients with an IVCD. They've shown the results are much better in terms of reducing the QRS duration and improvement in MHA functional class.
Your comments?
Yeah, so it was a nice presentation on rationale and evidence of conduction system pacing, particularly left bundle branch pacing as a CRT. But only thing we know that CSP can actually be used as an alternative, but I would like to know from you, because here majority are residents and exam going students. So what are the clinical features or clinical scenarios, ECG, imaging already you have discussed, where you would not consider CSP as a method of CRT alone. So CSP alone. So you would either uh, beforehand explain the patient that you would require, even if I am trying to do CSP, I would like to add a LV lead. So certain clinical diagnosis, certain ECG features that can, you know, that can be.
So clinically, any patient with the ischemic cardiomyopathy, they may have a scar here and there. So any patient with ischemic cardiomyopathy ultimately will end up in doing a left bundle lead along with the CSC, that's LOT CRT or LOT CRTD. So be careful in patients in choosing the patient when you have the option of doing dual chamber alone. So any patient with ischemic cardiomyopathy, or if the ECG is showing an atypical pattern of LBBP. In typical pattern of LBBP, these patients will be having LBBP associated cardiomyopathy, meaning that they'll have absolutely normal parameters apart from LBBP and LV dysfunction. But when you have an atypical ECG, when it is not fitting in Strauss criteria, when you have Q waves in lead 1, lead AVL, when you have a tall R waves in lead B1, or when you have concordant ST segment changes, then probably you may have to think of either an infiltrative variety of non-ischemic cardiomyopathy or an associated ischemic cardiomyopathy. So in those cases, you have to go in an idea of deploying both CS lead and left bundle branch lead, left bundle branch pacing lead. So if you have a typical, I think I will bet on Strauss criteria as one of the important thing to analyze before getting into the lab. So when the ECG is fitting into the Strauss criteria, and when the echo is showing a normal muscle thickness without any scar, and if you have an option of doing an MRI, it is well and good. Otherwise, if the echo is clean up scar, then probably left bundle lead alone will be good. On the other hand, atypical LBBP, ischemic cardiomyopathy, if you see some thinning here and there in the echocardiography or any non-LBBP pattern, you have to go with an idea of putting a CS lead along, CS lead also.
Sure. Vanita, your closing comments, and then you can start actually your presentation.
Well, it was a wonderful presentation from SS, as always, I should say. And I attended a debate in HRS 2024 in Boston, and it was the same discussion which was going on. The main consensus that came from there was that one, CRT is supported by a lot of randomized controlled trials. It is. And frankly speaking, we have huge data about it. It has been going on for almost 2 decades. Now, comparing it to a modality which has become a reality only 5 years ago with no randomized controlled trial, it is like apples and oranges being compared. But the consensus was that they are complementary to each other. So what SS says is that he starts with left bundle, and then if the QRS is not narrowed, then he adds a CS lead. If you are doing the other way around, you're not doing anything wrong. You are doing a good thing. You are doing it the right way. It's just how you are used to planning your case. And there is a comment from Apurva in the chat box. He is asking if we can do a CS, angiogram before deciding and starting to discuss. Basically looking at the anatomy of the coronary sinus, if it is acceptable. Well, that's a good start, of course. Why not start doing that? If you have a good vein, which is a posterolateral vein, go ahead and put in a lead there. And then you can go ahead and see if you have been able to narrow down the QRS. Don't put a left lead. But if you have not been able to do it, yes, go ahead and put a left lead. But the challenge is coming with the type of devices that we have, so that whenever we have to upgrade a patient from the who's coming for a replacement, in case now he requires a CRT or he's a failure of CRT, or now you want to add a left bundle lead. How do you use these devices? I'm told that Cobalt Chrome series, which has just been launched from Medtronic, they are coming with DF1 and DF4 both leads. They are coming with quadri as well as bipolar LV leads. So I think that should give us more options to decide how to proceed with the patients. And having said that, there is no doubt that this modality is wonderful. It has way to go. The randomized control trials, though they haven't come till now, but they will come. We have a trial coming up, left versus left, and the data of this trial is very, very promising. It will change. It will educate us further, and it will change our treating modality for such patients. So, moving on to my session here, the responsibility that Ashish gave to me is about a different modality of pacing, which we have been discussing. So, this is about a leadless pacemaker. How do we do leadless pacemaker, and what was the requirement of going in for another modality of pacing when we already are pacing our patients very, very nicely and in a good way? We're going to discuss about this small capsule which has come up. Now, before I start this talk of mine, I would like to tell the participants in this session, this is not the modality of choice for 100% patients. With conduction system pacing coming up in a beautiful way, this becomes the choiced modality for very specific patients. And I will show you the example, especially in our country, where the cost of therapy matters to our patients who are paying from the pocket. This has become a choice therapy for very significant number of patients, but with very specific indications, not all patients. So you all know how transvenous pacing is done. This is the conventional pacing that is done through the axillary or the subclavian venous route. You take an access, you implant this device under the collarbone, and you put in the leads in the right atrium as well as right ventricle, in whichever way you are comfortable to do. Now, over the time, there has been technological advancement to the reduction in size of the pacemaker and giving longevity in the devices, because so that the replacements are less over the time. But most of us have seen this kind of complications occurring over the time, which may be because of the abrasion, which may be because of the hematoma, which may be because of the device erosion. The leads specifically will give us a lot of trouble. The insulation break, the lead fractures, the wear and tear causes a havoc in the patient. And every time the patients, when they come with this problem, we are stuck up. Either we, because the extraction tools are again very expensive. It costs a huge amount of money to the patient. So we have been looking for another modality. Now you see the first human implant was done in 1967. And this is a paper from 1970. Since then, they have been looking to get rid of the leads and look for a new modality which can be placed in the right ventricle, and we can remove the entire trajectory which has been used to implant this. So this is within 3 years, they realized that long-term lead problems can be there. I'm not saying they are always there, but it can be there. So they have been looking up for the concept change. And this innovation occurred in 2013 when the first human implant was done and the leadless pacemaker became a reality. It was called micro pacemaker. Now it is called Micra. It has come from Medtronic. I went to Minneapolis in 2011 for Asia's device summit, and that was the first time I had my hands on this device, and I implanted actually in a pig. So 2011 to 2013, it became a reality in the human, and 2016, it came to India, and I went to Florida for again for the training, and we did the first human implant in India in 2016. So the entire trajectory has been compressed into a small capsule. Now these tines act as the leads. The trajectory circuitry board is there, and the battery is there. The battery life is good. It was launched as a VVIR pacemaker with a very small mass, that is 2 grams, and the width of this capsule was 20 French. So, which is the thickness, of course, is more. I'll just explain how we implant it. It was a MRI conditional up to 3 Tesla. The best part was that it can be programmed into a OO mode at the time of end of life. And it was a rate responsive pacemaker. So it has a rate responsive mode. That means it gives the modality gives with the functional capacity of the patient, it will increase the rate to the required thing. And the first study which came with 100% pace, the longevity was 9.1 years, which is quite good. Now, how do we implant this 20 French pacemaker? This is the sheath that is used. The outer lumen of this sheath is 27 French and the inner lumen of this sheath is 23 French. It's a hydrophilic sheath, so you have to wet it very nicely to introduce it in the groin. Once we take in the groin punch, I'm sorry about this. Let me stop it. Okay, so sorry about the volume. I always do a check shot on the venous, the femoral vein, to see the width and the patency of the vein, and that there should not be any narrowing or any problem there. And we have to dilate the vein gradually, taking dilators which are 16, 18, 20, 22 French, and then introduce this sheath in the groin. Oh, sorry. So this is how the capsule looks like on the catheter. This is capsule, and there are 3 knobs on this catheter. This is the locking knob. These are the tethers which pass through the capsule, the micra, and hold it. So this is the locking tool. This is the deflectable tool, and this is the deployment tool. So we prepare the leadless pacemaker outside. Sorry about this. We prepare the leadless pacemaker outside, and we attach a 50 cc syringe to the already this end of the catheter, and we take the leadless pacemaker in, and we are ready to introduce the pacemaker in the groin. So once the stiff wire has been passed into the SVC, then we have dilated the groin, it is ready. We pass the sheath over the stiff wire and we remove the dilator from the sheath. This is how it is introduced, and under fluoroscopy, we go ahead and see that it enters the sheath. We pull the sheath down into the IVC so that we can use the deflectable tool to give the angle on the micra sheath and to cross the tricuspid valve from here. Here it crosses the tricuspid valve, give an anti-clockwise torque to the catheter, and it is placed on the septum. This is the septum where it is placed, and we give a gooseneck. So once that is done, okay, we check it in the LAO and the RAO view. If we are happy, we give some dye. A 50 cc syringe is used to give the dye to look for the trabeculae. Once we find good trabeculae and we are convinced in the RAO as well as LAO view, we have to use both the views to see that. Then we go ahead and deploy the leadless pacemaker using the deployment tool. The deployment tool, we withdraw the catheter a little, and this is how it is released. Sometimes you see the dye staining in the catheter because the threads, the tethers which are holding the micra as well as the lumen through which you give the dye are in the same part of the sheath. That's why the dye sometimes sticks around. I run heparinized saline to make this the distancing between the micra and the catheter possible in a good way. So once this is done, we do the tug test. Now we pull the tethers with every beat and we see the movement of these tines. This is the tines. If more than 2 tines are moving when you are pulling the thread, that means you will require 15 times the force to hold the force is required to remove the micra. So it is a good thing if we can see at least 2 tines moving with your movement of the tethers. We do the electricals in case we are happy with the electricals, and we go ahead and accept it. Minded the electricals of micra are done not at 0.4 milliseconds of pulse width, it is done at 0.24 milliseconds of pulse width, and the threshold as low as possible is good. The R-way should be good and the impedance in the acceptable range. In case you have you are not happy with the electricals, what do you do? So as long as tethers are in your hand, you can actually recapture the leadless pacemaker and position it in a different place so that you get a good position and a good threshold for this leadless pacemaker. This is our happy team after the case. Now, as far as I am concerned, these happen to be the indications for doing a leadless pacemaker. AFib with a very slow rate, elderly person not moving around much. Then, in case patient has CKD, requires dialysis, and the shunts have to be placed in, have to be put in. A bad COPD patient. These form the main forma fiesta of indications for leadless pacemaker. But in our country, it has become another indication is the infection rate. That has become the indication for a pacemaker. I'll just show you a case. I was lucky enough to do the first live case implant in 2016 TCT India. So this is the case that I want to bring it to your notice. There was a 60-year-old male who was given a transvenous pacemaker in 2014 for complete heart block at a government hospital. He developed infection. So he went back to the hospital. They cleaned his pocket and put this pocket pacemaker in the same pocket. It got infected again. He went to the private hospital where they again opened the pocket and put the device deeper down into the pectoral region. After 3 years, his RV lead got malfunction. So then his RV lead was implanted and a new RV lead was implanted, but his site got infected again. This is how he presented with the site extrusion. And he was so much in pain and distress that it was inexplainable. So what we went ahead and removed all the leads and we placed the leadless pacemaker, and he has been doing fine since then. So now another case of a 75-year-old male who was totally emaciated and his weight was 33 kgs. He was a smoker, an old case of pulmonary cox, and he developed early fatigue syncope and a left bundle branch block on the ECG with ejection fraction of 35%. When I saw the ECG, I thought it was a clear-cut indication we should be doing a CRT in this patient. Because that will take care of his heart function also, his left bundle will get corrected, and CSP will also be taken care of. But then the referral told me to see the patient and you see the patient picture, I have put it there, and the X-rays. Look at the X-rays; they were humongous bullae at the apex, and I was very scared to put in a needle. And but plus the patient while he was lying down on the table, his anatomy was so good that I didn't have to actually palpate the artery. Artery was just seen there and the vein was just seen there. So we went ahead and took a venous shot and we put in a leadless pacemaker for this patient, and he went back home happy. Now, this is another patient. This is thanks to Dr. Jatinder Makkar, my friend from Jaipur, this is his case, and Kush must be remembering this. Kush is with Dr. Makkar in the same organization. A 63-year-old lady with diabetes, she had a rheumatic heart disease and underwent a mitral valve replacement. For severe TR, there was this perimount valve put in the tricuspid position. During the surgery, she developed CHB, so she was given an epicardial lead. Now, she presented with cardiac arrest a couple of months later and had to undergo CPR for that. And her epicardial lead actually had given way. So, saving her from a surgery, a repeat surgery, came to the rescue the leadless pacemaker, which this is the epicardial lead, and the leadless pacemaker was done. And with ease through this the valve, and the leadless pacemaker was placed in the RV, and patient did well since. Now, this is another patient who had a replacement for end of life done 2 years ago, and end of life of the pacemaker already implanted, and he was going around from last 2 years with this draining sinus, and staph positive patient, very distressed. So I went ahead, explanted this pacemaker and the leads, and then went ahead and put the leadless pacemaker at the same sitting. There has been no reported case of infection. You can even do leadless pacemaker in active infection. It is pretty safe. Now, another case with keloids, he had a bypass surgery, and look at his chest. Any scar would give him a keloid. His skin was so hyper reactive. And they also, his surgical wound also got infected. And he developed a complete heart block, intermittent complete heart block with syncope, left bundle he came to me with. And his EF was normal. So he asked for a pacing modality. I told him if I put in the pacemaker in the conventional area, then there is a high chance that he will again develop a keloid and it may get infected. So he accepted the leadless pacemaker, and we went ahead and did the implant there. A very interesting case. I did a triple M a couple of years ago. A 39-year-old male with 3 surgeries, cardiac surgeries in past, Bentals and AVR had been done. Now he developed a complete heart block. His venous access was a challenge, and from the past cannulations, the upper limb veins were totally blocked. And the surgeons refused to operate because his heart was actually just sticking to his sternum. So what do we do with this? The upper axis is gone. So we went ahead and did the leadless pacemaker. So initially we used to do leadless pacemaker at the apical septum. We used to place that at the apical septum. This was my first case where I went ahead and did it at the junction of mid to high septum. And the QRS which we got as a result actually was narrower than the TPI lead was when we were pacing him. The TPI lead was at the RV apex. So this was narrow. And I remember Dr. Ullas commenting that this is like doing his bundle pacing with a leadless pacemaker. And it may become a reality very soon, because I had a word with Dr. Sra, and he has developed a system where we can 3D mapping system, which can be, we can, on the fluoro, we can reimpose the 3D mapping map and have the entire conduction system delineated in front of us. And they're talking of doing a case, putting a leadless pacemaker at the left bundle using that map. So this may become a reality tomorrow. Now, I told you if the upper limb veins are a challenge, you can go ahead and do the leadless pacemaker through the femoral route. What if the lower limb is veins are the access challenge we get? Then what do we do? Look at this. This patient had a innominate draining into the hemiazygos with persistent left SVC, and the route of this wire, the stiff wire, is so tortuous, and I'm still in the not entered the RV, I am still in the RA. So this kind of a curve with single catheter access available from Micra from Medtronic, in fact, is very, very challenging, very difficult. So we had to think innovatively how to go about it. Well, we changed our thoughts. We went to the head end of the table, took a jugular access. The jugular access was easy, but putting in the sheath there was little difficult because the dilatation, I was very scared to put the stiff wire in the RV and dilate the veins. So I went ahead and put it through the RVOT into the pulmonary vasculature. That gave me a stable place for the vein to be for the stiff wire to be parked, and Soleil to dilate this jugular vein very nicely in these patients. And we once the sheath was introduced, the micra from the jugular root would just go into the coronary sinus. That is the easiest access. See, it is going into the coronary sinus. I had to manipulate it and a little and go into the RVOT, then pull it down. And once it was in the RV, the implantation of the micra was actually a piece of cake. So this is the patient. He was ready to be discharged 4 hours after the procedures because it was through the jugular root, so all went well. And then Dr. Shunmuga just spoke about the scar. The scar in the LV has to be defined. Well, scar in the RV also has to be defined because sometimes that can give us trouble to implant the micra also. This is a patient who came with the intermittent complete heart block, and he had a normal LV function. I'm sorry about this. He had a normal LV function. I went ahead, the access was quite simple. I went ahead and crossed the tricuspid valve and placed the catheter nicely in the mid-septal position, which is ideal for the leadless pacemaker. And when I did the shot for the checking the trabeculae, look at this. I could see a kind of, I don't know, this structure there, which was staining a lot. I thought it was a trabeculae stain. It was much more than the staining was much more than normally it is. But I accepted it and kind of implanted the micra there. And once I implanted the micra there, there was sensing was okay, but it was just not pace. It was just not pacing. And even in the normal LV function, sometimes you can get stuck up with such kind of anatomy. And so I retracted the leadless pacemaker back, tried to reposition it at a different place, but it kept going in this either in the apex or in the same place. So with a lot of technical difficulty and no, I would say technical challenge, I finally found a place where I could place the leadless pacemaker away from this site. See, it kept going there and there only. The same place it was going, or it was going at the apex. Ultimately, I found a good site, and then we got good trabeculae there. It was at the apical septum. It was not at the apex, but it was almost the apical septum. We found good trabeculae there. The position was stable, and we implanted the leadless pacemaker with a good threshold and good outcome. So this was, I would say, technically speaking, the most challenging case I've ever done. Finding a small place with that whole area of scar, I don't know. It was the most difficult case, but the patient did well. And with that, I would, of course, say thank you and thank you for listening. Until unless I have a minute to discuss about the AV micra.
Yeah, sure. Very relevant.
Okay, so we started with BVIR micra, but then, the algorithm was developed to actually study the P wave. The A4, which is actually the atrial systole, during which the blood is pushed into the ventricle. That was 100 millisecond electromechanical delay was seen. It corresponded to the A wave at the Doppler, echo Doppler that we see. So this A4 became very important, and on the paper it looked good. It corresponded to the P wave, 100 milliseconds mechanical delay was given, and we started sensing the A wave and pacing the ventricle. Now, it is never 100% sensing as it was in the VDD pacemaker, which came with a single lead earlier. So there also the AV synchrony was maintained at about 80%. So we had to control the atrial rate to around 70, 80. And if the rate goes high, if the atrial rate goes high, the AV synchrony would go. Similarly, here too, the A4 has been sensed and about 80% in the trial. And 80% is also pretty good for these patients, in case we are able to do it. That's how it came in the concept of AV Micra. And it is the implantation technique is absolutely same, and the features are all the same. It is again 3 Tesla MRI compatible. The longevity, of course, is a little less as compared to VR Micra because of the atrial sensing. They say it is around 10 years as of now. So, but it is a good modality, and this is the next step we are going to take. January 2025, we are going to have AVR coming from Abbott, which is an actual dual chamber leadless pacemaker with 2 capsules, one in the atria, one in the ventricle. The implantation technique is different, but very promising. And Vivek Reddy was the first one who did it in Parag. And the implantation technique is that the atrial pacemaker goes in the RA appendage. We actually have to define the RA appendage and we implant it there. And the lower chamber ventricle pacemaker goes as per in the septum. The technique is different. There are no tines, but it is actually a screw-in mechanism which takes the AVR in their specific positions. So that's all for now. Thank you so much for your patient hearing.
Sure, great as usual, Vanita. I'll request quick one comment from both Haigreve and Niranjan, and then we can move on in the interest of time. Sure.
I think I overshot the time a little.
Doesn't matter, as we said, it
Sorry.
helps. Sure. Haigreve and Neeraj, one quick comment.
Yeah, it's a great presentation with multiple good cases actually, which are do by routine stuff. The very first statement of Vanita is important for all students to understand. She said that
Connection
is a
broke.
little, yeah.
I think we've lost him.
Neeraj, you chip in, and if we
Yeah.
get Haigreve back, then.
Yeah, so very nice, ma'am, and a lot of scope of this leadless pacemaker has been discussed by madam with different case scenario. So we should
described in
understand
the
that
cases is that they are taken care of by limited surgery.
Haigreve, your connectivity is a little problem. Neeraj.
He got disconnected. Neeraj, go ahead.
Yes, so lot of indications, specific indications that has been discussed by madam, and that has to be kept in mind. Definitely, it's a leadless pacemaker, but the studies have shown that it is not without complications. So we have to be very specific to make it, make it more useful for our patients. So it was a very nice presentation. Thank you.
Vanita, what I find interesting in these leadless pacemakers is that when you have an infected device, it's good that you can take the device out and on the same table put a Micra in, and you don't really have to wait for the infection to heal. That in a dependent patient is a big boon to save the hospitalization.
It is a solace, definitely.
Very small question. Do you have any case of leadless pacemaker dislodgement in follow-up?
No, push no.
No.
I'm very sure I do not cut my tines till I see at least 3. I do not cut the tethers till I see the 3 tines moving. I'm very sure about it. And as Neeraj said, it is correct. It is not without complications. there are complications and they have occurred in specific hands in India also. But I insist and re-insist on the statement that it should be done by trained hands. It should not be a technology given to anybody and everybody. Medtronic has been trying to do that. And I have been telling them, I said, why don't you have a trainer? I have become a trainer. And I tell them, I said, 3 cases, you train the person. If he's good, confident after that, of course, go ahead and let them do the independent implants. But training is very important, Neeraj, and you are right about it. I mean, I am very pro that.
Sure. So Suchit is waiting and we let him do his presentation. Suchit, come on.
Thank you for after this nice talks I heard from Sundaram and Vanita madam. So my topic is about multi-site pacing concept. So I'm just sharing my slides. 1 second. So first of all, this is a very good platform. I think actually the enthusiasm of Ashish Nabar sir is keeping it live, and I think it is improving day by day. So it is a great platform for the DNB trainees to learn new things in electrophysiology and devices. So beginning my talk, so what is the concept of multi-site pacing and why it is important? So the CRT response is something which is not 100%. So, and if it responds, it is a boon to the patient of heart failure. So large randomized trials have demonstrated that CRT improves the quality of life and reduces heart failure hospitalizations, mortality, and reverses the structural remodeling of the heart. And after everything, clinical response to CRT is variable, with up to around 30% patients not responding to CRT. So there are multiple reasons for non-response. Most important of these are patient selection, inadequate delivery of cardiac resynchronization, that is intraoperative selection of veins, good parameters, and lead position. So what are the factors important for CRT response? Underlying heart disease. So patients with heart failure with ischemic causes and a high scar burden have a worse CRT response rate compared with those with non-ischemic causes. Patients who have non-left bundle branch block QRS patterns and the QRS duration of less than 150 millisecond have lower response rate. Intraoperative decision on placing the LV lead at the site of latest activation, that can be done by QLV values more than 95 or a speckle tracking guided. There are 2 trials which looked at this. I think the speckle tracking one was a target trial. So all these trials have looked at this, and this has shown that placing the lead at the site of the latest activation improves the outcomes. And why this is important? Because if you see the survival at 5 years is very good for super responders, then 70% for responders, and it is bad for non-responders. So these are the survival curves, which is significantly different between the 3 groups. And this responders is clinical response and also echocardiographic response, that is if the end systolic volume is decreased by more than 15%. And even if the mortality rate, if you see that super responder versus non-responder, there is a 34% mortality benefit. Responder versus non-responder, there is a 22% mortality benefit. This is quite significant. So how to reduce these non-responders? Because non-responders are still 30%, and there should be ways to reduce it. I think first is implantation as case selection. So if you select the case for the proper indications, you have an LBBB with a wide QRS more than 150, you are more likely to achieve a good response rate. But ischemic cardiomyopathy and a huge scar burden, there can be non-response also. That depends on the case. Second is implantation technique. When you are implanting, always implant in a posterolateral vein, and it should not be a apical implant. It should be mid or basal side mostly. And also you have to check the QLV while implanting, and also electrical and anatomic separation should be maintained. So anatomic separation more than 30 millimeters should be there at least. So these are important. Second, after implantation of CRT, it doesn't end there. So you have to optimize the CRT also, and see that the ECG is narrowed after the CRT. And also you have to look at some arrhythmias are occurring or not. For example, if you have significant number of VPCs, which can reduce the CRT percentage. So you have to ablate those VPCs, and then the CRT percentage will improve. So these are taken care of by this. Now, what is for multi-site pacing? So multi-site pacing is another way by which you can tackle non-response. So multi-site pacing is that it will pace in two different vectors. So if you can see here, there are two different vectors. One vector is between the distal pole of the quadripolar lead in the coronary sinus vein, and then the RV coil. And the second pole is between the maybe M2P4 or a D1P4. So if you combine these two poles, these two vectors, it is called as a multi-site pacing. So simultaneously, you are using two vectors with two different, maybe with two different parameters also, and two different delays. So that will help in capturing a huge part of LV, preferentially to synchronize it. Now you can use different ways to multi-site pacing. The most commonly used now is a multipolar CS lead, because we have many multipolar CS leads where you can have the facility of electrical repositioning also. So there has been studies which studied two RV leads also, and one RV and two CS leads. But if you take two CS leads, this can be technically challenging. It may not be done in all cases. So these are the different multipolar leads we have. So multipolar leads give an advantage of choosing different vectors and also placing them according to the vein size. Now coming to the physiological rationale of a multipolar multi-site pacing. So we know that even among LVV patients, there is a heterogeneity in the location of the conduction block and resulting LV activation pattern. There are two types of LV activation seen by electroanatomical mapping. One is called as type 1 activation, where the LV is activated from the septum and then it gradually spreads to the lateral wall. The type 2 activation is an U-shaped activation pattern, and this is resulting from a functional conduction block. So it has been shown that the type 2 activation pattern is more amenable to correction by LV stimulation, and indeed this pattern is associated with a favorable response to CRT. A further determinant of CRT response may be the presence, location and burden of myocardial scar and the position of LV lead with respect to these scarred regions. An implantation of LV lead in an area of myocardial scar may be associated with slow conduction and block, resulting in less hemodynamic improvement and a poor clinical outcome. And there is considerable heterogeneity in the myocardial substrate of patients receiving CRT. That is the case selection. In particular, in the etiology of heart failure and the location of conduction block within the heart. So I think Dr. Sundaram has already discussed that the scar within the heart differs according to ischemic cardiomyopathy, non-ischemic cardiomyopathy, even among the ischemic cardiomyopathy. So majority of patients with a non-ischemic heart failure etiology or functional block responded to conventional single-site CRT, whereas those with myocardial scar or the absence of functional block often required MSP to achieve CRT response in one study. So they showed that if you have a single site, if you have a non-ischemic heart failure, that responded very well to a single site CRT, while if you have a ischemic heart disease with a huge myocardial scar and absence of functional block often required multi-site pacing. So that involves capturing both sides of the scar. Now, how multi-site pacing of LV helps? With an electrical wavefront originating in the right ventricle and from two separate LV sites, the systolic contraction of LV is likely to complete in a shorter ejection time, leading to a more synchronous ventricular contraction. In addition, pacing the LV at two separate sites increases the probabilistic chance of one of the two pacing electrodes being at or close to the optimal pacing site through electrical repositioning. And also, if you pace at both edges of the scar, there is a homogeneous activation in that area. So if you see here, it is a diagrammatic representation of a single site pacing versus multi-site pacing. You see the wavefronts of activation are more homogeneous when you have encountered different scars. But if you are spacing in a single site, then there are lines of conduction block which develop because of the scar. And so So multi-site pacing from a single CS branch, you can use any two vectors using different cathodes as selected, and then you can have different vectors and different even pulse width and different also amplitude. And pacing sequences and delay, that also you need to adjust in a multi-site pacing. So you can put as an LV first and LV electrodes first and then RV, then you can make it as an RV first also based on the disease. Okay. So what are the clinical studies which look at this multi-site pacing? The larger studies, if we look at, is the MPP trial. This MPP trial was a multi-center prospective randomized double-blind clinical trial. It took non-responders at 3 months to CRT to either MPP or continued biventricular pacing. And safety endpoint was met at 93%, and intention to treat with equal response rate with MPP, but those with anatomically separate electrode pacing, that is if the two anatomical electrodes in multi-point pacing are more than 30 millimeter, they were associated with a higher response compared to biventricular pacing and higher conversion from non-responder to responder. Another important trial I want to look at is SMART MSP trial. The SMART MSP trial is a multi-center prospective single-arm non-randomized trial. Non-responders at 6 months by clinical composite score had either MPP turned on and followed for additional 6 months or continued by V. MPP related complication was complication free rate was 99%, so it is safe. There was a battery impact of 3 to 4 months. So what happens is that when you have multi-point pacing, or so the impedance comes down because there are 2 points you are pacing. So whenever the impedance comes down, the current flow increases, and whenever the current flow increases, the battery drain increases. So, but this trial has shown the maximum impact of battery is only 3 to 4 months, and there was improved CCS score at 6 to 12 months at 51%. So this is the way this SMART MSP trial was conducted. So the non-responders to conventional CRT were allowed to either continue with BiV or with a multi-site pacing. So 51% of the patients who were non-responders on conventional CRT became responders with the activation of multi-site pacing. And on subgroup analysis, it showed that the use of a proximal most electrode in the quadripolar LV lead was associated with a higher response rate. There is another trial which is more recent. It came in, I think, October 2023. This is the MORE CRT MPP trial. Now, in this trial, the CRT responders and non-responders at 6 months of biventricular pacing, where non-responders were randomized to 12 months of either continued biventricular pacing or a multi-point pacing. And outcome was assessed in 2 ways, either in intention to treat analysis or to see in patients intention to treat analysis patient with ventricular pacing of more than 98%. If you only take the intention to treat analysis, you can see that there was no statistical difference between the MPP arm and BiV arm. So in that way, it was a negative trial. While if you consider only the ventricular pacing of more than 98%, there was a significant difference between the 2 groups. Now coming to the downside, so we showed the different trials which showed a benefit of multi-site pacing, and I showed also one negative trial which did not show that much benefit with multi-point pacing. Now what is the downside of a multi-site pacing? So if dual leads we are not using now, so I am not skipping that part, but if you have a multipolar lead also and different vectors at the same time, you can have a decreased battery life of around 3 to 4 months. And also there is a risk of proarrhythmia because CRT, it is an abnormal activation wavefront. So our normal activation is from endocardium to epicardium when our normal His-Parkinson system related activation occurs. In CRT, we are activating from epicardium to endocardium. Now when that occurs, theoretically there is an increased risk of proarrhythmia, but different studies have not conclusively proven any significant proarrhythmia of these leads. So in conclusion, multi-site pacing may be required in certain subset of patients undergoing CRT, particularly those with ischemic cardiomyopathy and a huge scar burden and a narrower QRS. it is important in having in patients having extensive scarring where CRT and even CSP doesn't achieve resynchronization well. It can improve response rate when switched on in non-responders, and there is a minimal more battery drain due to a lowered impedance and more current flow. Thank you.
Sure. Dr. Vanita and Dr. Neeraj, a quick discussion. Well, I want to ask you, Suchit, this one cause of non-responder is also atrial fibrillation. For the benefit of the postgraduates, how do you tackle atrial fibrillation in patients who have a CRT?
So I think there are different trials where atrial fibrillation in heart failure has shown if you ablate those patients, then there is a increased chance of CRT will be active in those patients, because there are different algorithms. But if you can ablate the atrial fibrillation even in a patient of heart failure, that has shown significant decrease of the hospitalization and benefits. So if you can't ablate, then there is different ways you can deal with. There are some algorithms also in the devices where in presence of AF, they increase the rate of pacing or smoothen the response so that you have more CRT. Now, so one is an ablation.
So,
and there
Suchit, by ablation, you mean that if it's a paroxysmal or persistent AF, you will do a PV isolation.
correct.
And if it is
And
a
also,
permanent AF, you'll ablate the AV node, right?
yes, so it's a permanent AF, we can ablate the AV node, but that should be the last resort, I mean to say. So you should also try to maintain the rhythm if possible. Means you can try for cardioversion, drug therapy, AFib ablation if possible, then algorithms, and then if it is not maintaining, you can go for AV node ablation. That is very good if other things are not working. That is my idea.
Neeraj.
Yeah, so a lot of importance is given to LV lead and left ventricle in CRT, but very important chamber is atrium in CRT, and particularly the parameters that we get from the atrial lead. So one has to be very sure that atrial lead is sensing well, then only the effective CRT will be delivered, right? And whenever atrial fibrillation happens, management of atrial fibrillation remains the cornerstone, depending on the feasibility of PVI and maintaining sinus rhythm. That that would take the priority. And if it is an advanced stage, adversely remodeled atria, then definitely the AV node ablation is going to be very helpful in managing this patient. Second, this regarding MPP, MPS, multi-site pacing, it was a very excellent talk overviewing the rationale and evidence that we have. Uh, Obviously, from the evidence that you have shown, what are the subgroup of patients that I would like to know where you would clearly tell that you have to spend some extra money, for the CRT device having MSP feature, because there is a huge, difference in the costing of devices where multi-site pacing is available.
So I think that's a very good question. So if we look at the concept of multi-site pacing, that is more important in patients with an ischemic cardiomyopathy, which have very high burden of scar or not that much wide QRS. So these are the subgroups which have shown that if you have a multi-site pacing, you can capture both sides of the scar, or if one of the electrodes is in scar, the other electrodes will be outside scar. So you have multiple areas where you can make different vectors and capture it. And also another important point is that so it allows that if you have a multi vector, so you are more likely to be at the latest area of LV activation rather than if you have a single vector. That is probabilistically. So I think these two, and I think multi-site pacing should not be switched on at the first instance. That is my idea. You try a CRT, you wait for some time, maybe 3 months to 6 months, and see how is the CRT response. If the CRT response is good, then no need. Even if you have that subset to switch on multi-site pacing, you can have the luxury of having that in this sort of patients, but switch on only when you are not achieving CRT by 6 months.
Yes, so
Also,
that
the
was
battery life also it decreases significantly if you switch on the multi-site pacing. That is also
Yeah,
a very
so that
important
they
part.
have mentioned is around 3 to 4 months in the smart MSP study. That is there. That is there, sure.
Yeah, so the incremental benefit of MSP comes when patient has not responded to the conventional way of
Correct.
pacing.
And you
So it
don't
is
find any
always
other
a
cause.
yeah, so it is always a good practice not to switch it on from the beginning. Just reassess the patient after 3 6 months, and then look if patient has not responded very well. You can switch on the MSP and hope that it comes into those 50% of increase in response rate that is shown in this smart MSP trial. Thank you. We'll I think move on to next.
Yeah, we move on to push. I think remote monitoring, the uptake of it, why is it less in India? Is it related to the battery that is getting lost? Is it related to the compensation to the physician? Is it related to not having a dedicated team to deal with the frequent messages that you get? What is it? I think Kush will tell us all you need to know about remote monitoring, and hopefully you'll be convinced to increase its uptake in our practice. Sure,
Yes,
push.
sir. Yeah, thank you so much, sir. First of all, for giving me an opportunity to take this talk on remote monitoring, which is actually a very important topic. Because if we compare the Western world as and the Indian world, there are a lot of patients in India who are actually not on remote monitoring, but in the Western world, many patients are there on remote monitoring. So, what are the advantages of remote monitoring? So, remote monitoring is reshaping device follow-up and care for patients. So, what is the usual trend now? What we are following is that patient comes to us in the office or clinic. We use a programmer, and then we interrogate the pacemaker or the device, which can be either manual or wireless, and then we give them the reports. If there is any problem, then we tackle that. But now, with the help of remote monitoring, patient need not come to the office or clinic. So they have an instrument along with them, which can connect with their pacemakers or ICDs, and then they can send the data directly to the server, and then the server, we can use the server, and using the website, we can assess the data. So I'll come back to that later on. So with the help of remote monitoring, we can get almost all the things. We can get the parameters of the pacemakers. We can look about the integrity of the leads, about the battery status. If it's a CRT device, we can look at the various algorithms for the heart failure. We can have a look at the thoracic impedance, which can tell us beforehand only whether patient is having any symptoms of patient might have any symptoms of heart failure in future. Along with that, there are various other algorithms which can help us to monitor the patient, and patient need not come to the clinic. This is a very important part. So these are basic objectives to improve the monitoring efficiency and improve the patient outcome. How it will monitor, how it will help in improving monitoring efficiency by safely replacing in-office follow-ups. So by the help of remote monitoring, almost 70%, because 70% of the ambulatory pacemaker patient visits were not contributed based on this COMPASS trial. And by the help of remote monitoring, it replaces in-office follow-ups, avoids patient traveling and visit scheduling. As Vanita ma'am was telling, especially during COVID time, we all know that travel was a major factor. A patient couldn't travel. So with the help of this remote monitoring, patient can send their data, and physicians can review the data at their convenient time. So not only that, so it also maintains the home monitoring. With the help of home monitoring, there is a significant reduce in the in-office follow-ups by up to 45%. And not only that, it also decreases the mortality. So various trials were done. I'll discuss the various trials. This is the the result from the in-time study, that all-cause mortality reduction with the help of home monitoring was more than 50%. And not only that, it is the percentage of the remote monitoring as well. So patients with high adherence to remote monitoring, they have been shown to have 53% greater survival. So remote monitoring high versus low, definitely there was a difference. And remote monitoring low versus none, significant difference in survival. So this is actually what is a remote monitor. So this is the one with the Biotronic. We call it the Cardio Messenger Smart. So this is just like a mobile phone, which patient has to keep along with him near the bedside. And what this will do, patient is at home with the the implant. So there will be an automatic transmission of all device data. No patient interaction is required. With the help of this Cardio Messenger mobile patient device, it will transmit the data via secure cellular network to the service center, and they will analyze the data. And then we have the websites, we have the username, login, password. We can just log in on that website and we can assess the patient data. And with the help of these data, we can assess the complete event reports, including the high definition intracardiac EGMs. And it is a very user-friendly report. So this is the kind of report which we can get in the PDF form, and almost all the data of the device we can get. And again, patient need not come to the hospital. Just they have to, as sir was discussing about the battery life, so there is negligible battery drain of only 2% over the entire service lifetime of the device. So 98% remaining battery life of the device with daily transmission. So battery life is not a major concern if we talk about pacemakers. In fact, with CRTs and ICDs, it will actually help to improve the battery life. I'll come to that point later in my presentation. So the device longevity is absolutely uncompromised. And there's automatic data transmission from day one, and more than 90% transmission reliability is there. So it is reliable, it is efficient, and it is very easy. Basically, patient doesn't have to do anything, just have to keep their mobile this device near his bedside, and automatically it will get connected with that device. And there's a fixed time the data will be transmitted directly to the server. So we can get the early detection allows early intervention. So with the help of the EGMs, we can see whether patient having any problem or not. Like this patient was having a lot of atrial arrhythmia. Suppose this patient has been implanted in CRT, and we can see that there's a lot of atrial arrhythmias, because of which the CRT pacing percentage is very less. So we can tell the patient, we can do a telephonic consultation, and we can tell the patient that there's some problem in the device and we need to optimize the medications. So this is the report which we get. It's a one-page summary report about the device function status, about the arrhythmia detection and the other key findings, the device programming settings, and the key statistical trends. All this data will be there in the PDF form. So that was the Biotronic one, and this is the Merlin device. Again, same mechanism, just they have to keep this device near the bedside. And suppose an ICD patient is there, he feels that suppose he gets a shock at around 1 o'clock in the afternoon, then he doesn't need to do anything. It just, if this monitor is there, you just have to press the button and the data will be transmitted directly to the server, and doctor can assess that data within just few minutes. So as I discussed, there are a lot of patient benefits, there's a lot of physician benefits, and definitely the quality of life is significantly better. So what are the guidelines? So what does guideline have to say? So according to the IHRS guideline in 2000, which was published in 2015, a strategy of remote CID monitoring and interrogation, that is basically remote monitoring, combined with at least annual IPE, is recommended over a calendar-based schedule of in-person CID evaluation alone, when technically feasible, with class 1 recommendation and level of evidence A. That means that we should use remote monitoring as far as possible with a class 1 and recommendation and level of evidence A. And all patients with CIDs should be offered a remote monitoring as part of standard follow-up management strategy. So very important. We should counsel each and every patient that there's a remote monitoring facility available and you should avail that facility. So these data are not these are based on the clinical trials. So there are a lot of clinical trials which were done, which were done either on the pacemakers or ICDs and CRTs, and which has the various objectives of safety and efficacy and the other things. And so this was the impact of home monitoring. So for every 1,000 patients per year, home monitoring is estimated to achieve So there are a lot of things it can achieve. So most importantly, up to 53 lives saved. So it has a mortality benefit. And most importantly, 1100 fewer follow-up visits. So no need to visit the physician clinic. So basically the time of the patient, travel time, and the physician time also gets saved. And it decreases the mortality. How? I'll tell later. So 50% reduction in all-cause mortality. And home monitoring reduces worsening heart failure. So this was a study which was done, the end time study, and fewer patients in the home monitoring group compared with the patients in the control group had a worsened composite clinical score. So which was 18%, almost 19% as compared to the 27.5% patients in the control group. So it also reduces the heart failure. It again, by reducing the heart failure, it reduces the hospitalization. It also reduces, the home monitoring helps in reducing the inappropriate shock. So this was a study which was done, the ECOST randomized control trial. Home monitoring effectively halved the proportion of ICD patients receiving inappropriate shock. It extends device longevity. So by reducing the total number of shocks, it actually enhances the device longevity, especially in ICDs and CRTDs. So home monitoring detects the events earlier. So home monitoring significantly reduces the median time from symptomatic event onset to physician evaluation. Also, it maintains the patient adherence. As we all know that it's very difficult, especially for the Indian patients, to counsel the patients and that you need an annual follow-up or, a thrice, once in a 3 months follow-up, they need to come to the clinic for the device interrogation. It's very difficult to convince them. So calendar-based in-clinic follow-up is associated with decline in patients' adherence to visit. And here comes the role of the remote monitoring, because if you have a remote monitor in place, then there is no need to come to the clinic, and patient adherence is very much better when they have the remote monitoring. And also it detects the asymptomatic technical events better. So home monitoring enhances patient safety by detecting symptomatic and asymptomatic technical events like lead failures prior to the conventional follow-up visits. So all these, the trust RCDs, it has clearly shown that it detected 2 times technical events as compared to the conventional follow-up. Also, it has associated with a high level of patient satisfaction. And we all know that most of the standard follow-up visits, it actually unnecessary and therefore a chronic waste of healthcare resources, because almost 70% of the time the patient visits, it is basically non-actionable. Only 30% of the visits are actually actionable. So there was a meta-analysis which was done, and it was published in European Heart Journal, and it actually explains the significant survival benefit of ICD and CRTD with heart failure. So it was an analysis of the 3 randomized control trial, end time, ECOST, and trust trial. And these meta-analysis, it clearly showed the 38% reduction of all-cause mortality at 1 year, home monitoring versus the control group. And not only the mortality, but the heart failure hospitalization with remote monitoring. So this meta-analysis concluded that home monitoring with daily verification of transmission, it is associated with a consistent reduction of clinically relevant endpoints, all-cause mortality or heart failure, worsening heart failure hospitalization, and worsening heart failure mortality or hospitalization. So benefit is likely driven by prevention of heart failure exacerbation. And survival benefits observed in non-randomized registries are promising, but require confirmation in randomized control trial. So how it is going to actually benefit in the heart failure patients? So if we talk about the patients with heart failure who have been implanted ICD and CRTD, so so this was a trial, and what it does basically, what remote monitoring does, so we have a lot of parameters, disease and patient relevant set of rhythmological and technical parameters. This was a trial, in time trial, and so these parameters we can get to know before patient decompensates. So there are changes in the pressure, autonomic adaptation, thoracic impedance, before actually patient develops heart failure symptoms. And these are the parameters which the device, the CRTD device, they can detect, and they can, by the help of remote monitor, we can see the data, and we can we can counsel the patient that you are having some problem in the thoracic impedance and other parameters, and you might go in decomposition and land up in heart failure. So you need to optimize your medications. So what we have done. So based on these data, we have optimized the medication, and because of which patient does not decompensate, the heart failure hospitalization decreases. And there's automatic data collection. There's no patient involvement. So what are the programmable alerts? So there is atrial blood burden. So just we were talking about the atrial arrhythmias, CRT percentage pacing. So mean ventricular heart rate during arrhythmias and at rest. And the PVC burden. We all know that if there's a high PVC burden, the percentage of CRT pacing will be less. So these are the various things which device can monitor, along with the thoracic impedance, patient activity, heart rate variability, PVC, CRT pacing percentage, atrial burden, along with NSVT and VT runs. So these are the extensive heart failure diagnostic which the device will do and let us know that there's any problem in the patient or not, and we can optimize the medications. So these are the actual charts which we can get with the help of remote monitoring. We can get the chart of the thoracic impedance. Like in this patient, we can see that the atrial burden per day, it significantly increased, CRT pacing percentage decreased. So remote evaluation of the heart failure status. So there is serious changes in health status requiring timely intervention, early signs of worsening heart failure, effectiveness of CRT device therapy. So percentage pacing is less, then we need to optimize the medications, and underlying cause of patient's heart failure symptoms. So this was the case that patient hospitalized due to severe dyspnea at rest. Basically, patient landed up with ventricular failure, LVF ventricular failure, and there was pulmonary edema. And we can see, if we see the device data, that on almost in October 31st, patient got admitted. And if we look at the previous data, we can see that there's a decrease in the thoracic impedance, suggestive of fluid in the lungs, and there was high AF burden, I mean atrial tachyarrhythmias. So this was the reason basically because of which patient landed up in heart failure. So if we could have, if patient was having remote monitor, then probably almost a month, almost 20 days back, we could have seen that patient was might have symptoms of heart failure, and we could have optimized the medications. And if there's a high atrial burden, then patient could have been counseled, like Dr. Suchit said, the radiofrequency ablation or the various medications. So this is how the PDF, this is actual what we get with the help of remote monitoring. It's very simple. We just have to log in. We have a username, password, the website, and just have to click on the patient and the data. We can get all these data. So these four important study, TRUST study, End Time, E-Cost, and COMPASS study, so clearly shows that it reduces in-office follow-up burden and provides earlier detection of arrhythmias. Home monitoring causes decrease in mortality in heart failure patients. E-Cost study, it significantly reduces inappropriate shock and extends pathology. How it decreases inappropriate shock? By improving the heart failure. Once your heart failure gets improved, then definitely the chances of arrhythmias also gets improves. And it reduces in-office follow-ups and hospitalization for atrial arrhythmia and related stroke. So very important. So especially also in pacemakers and CRTs and ICDs, if there's atrial arrhythmia, we need to give them, the antiarrhythmic medications along with anticoagulation if patient is it falls in the category of that. And if we give them anticoagulation, then the hospital admission because of stroke also decreased. So this was shown in this COMPASS study. So these are the various, the monitoring devices of the various company which we have. But now there's also advancement in the remote monitoring technology. So there's a Bluetooth technology. We all know about the Bluetooth, the ICDs, the Bluetooth CRT, the Bluetooth pacemakers, which are available. So if we implant these devices, then probably patient does not need to keep these bedside monitors with them. So this Bluetooth enabled smartphone remote monitoring. So it will get connected with the patient's phone itself. And there's an app, patient can download the app. So there's an implantable device with the help of Bluetooth, patient smartphone. Device pairs with the My Merlin Pulse app, which is there using the Bluetooth wireless technology. and then they can transmit the data. And this is actually what it looks like. And when the data is transmitted, we will have this kind of report, which will tell us everything about the device, about the parameters, about the diagnostics, and whether there's any ATAF or VTBF episode or not. So then in that case, patient does not even need to keep a remote monitoring device with them. This Bluetooth device is more than sufficient. And so it has been shown that if patient is using these mobile app-based remote monitoring device, then patient engagement was strong, with majority of patients frequently opening and interacting with the app, and patients are actively engaging with the app to complete app-based reminders. So just few cases. So this is what we get: the past path summary, the diagnostic summary, the episode summary. And if we want to see, suppose the patient tells that he received a shock, he can immediately, on the mobile, he can send the data to the server. We can assess the data, and we can see whether patient had actual, the shock was because of actual VT. I mean, it was an appropriate shock or an inappropriate shock. So if it's on an inappropriate shock because of some lead malfunction, we can immediately tell the patient that there's a problem. He needs to visit the clinic on an urgent basis. Suppose it was a VT, and because of that patient received a shock, then we can tell them to optimize the medications. It was an appropriate shock. And we can see the actual EGMs. So these are the EGMs to support any alert. We can confirm whether it was based on these EGMs, we can see, we can tell them whether it was an appropriate shock or an inappropriate shock. So this was the patient during COVID time. He had an episode of ventricular tachycardia, and the device detected it correctly, and it gave shock to the patient. The patient called the doctor and told them about the shock. He saw this report, and it was an appropriate shock. So we can just optimize the medications, maybe increase the dose of antiarrhythmics or beta blockers. Again, ATAF detection can be done very easily. And if ATAF, atrial tachyarrhythmias are there, then he can undergo medical management or AF ablations if required. Then it can also tell us about the lead position. So this was the patient, 40-year-old male. He was implanted CRT-D for DCMP, and because of LV dysfunction, 30%. And this was the remote monitoring, the status which was few days post implant. So we can see that there is actually no bileal pacing in this patient because of the atrial lead dislodgement. And when the lead was repositioned, CRT pacing was back to normal. So a lot of things can be done with the help of remote monitoring. But as Sir mentioned, that India has very low remote monitoring incorporation as of now. And the main reason is obviously financial issues. But if we counsel the patients that if you get these remote monitors or maybe a Bluetooth device, then probably in follow-up, the office visits will be very less. And not only that, office visits will be really less, the travel cost will be less. But also, if there's any problem in the device, we can tell us beforehand only. And for CRTDs, we can tell them that if you have any symptoms of heart failure, then we can know beforehand only that you're going to land up in heart failure. So remote monitoring data analytics have potential to change the clinical practice permanently. The success is dependent upon the patient education, local workflows, and definitely industry support is also very important, because then these devices are very expensive. And future remote monitoring may integrate data from non-implantable devices like blood pressure monitoring, ECG, etc. So with that, I would like to end my presentation. And probably healthcare monitoring is moving, actually it's moving close to the patients, not just the remote monitors. We have a lot of other things in the industry which helps in moving the healthcare close to the patient.
Yeah, that last slide of yours, one can have again a full seminar on digital monitoring. So we have crossed much to our time, but I'll request Dr. Vanita, Dr. Neeraj, and Dr. Hygreave to tell us shortly as to how much they use remote monitoring in their practice, and then we can go ahead to close this session for today. Hygreave, you want to come in first?
Yeah. Overall, actually, before that, I want to congratulate Dr. Ashish Nabar, Vanita, for bringing a very good program today. They've taken technology, exposed the DNB students to the next level of technology in a very, and the speakers have done a wonderful job, each of them, to a nutshell. Now, coming to your point of remote monitoring, a very good talk by Kush Bhagat, and I call quite a passionate talk, I should say, promoting remote monitoring. There is no question about the science of remote monitoring. We are all in agreement with it. Ashish Nabar had in the introduction itself, had summarized all the problems in India in a very nutshell, in 3 sentences. He had said that the challenges of adopting remote monitoring in India exist. There's so many. Actually, that is a seminar by itself, not this forum actually, because the issues of adopting remote monitoring in India are not science or not finance also, as Kush thinks. Actually, it is more of logistics. Because you need an organization. There's too much. The bulk of the practice in India is individualized private practice, and the government hospitals are also not, the institutions in government hospitals are also not taken up as a department. You need to have a systematic for a place, a structure in the hospital where these and personnel who are trained in it, because it's a 24/7 service and it cannot be individual monitoring. That actually limits we do practice, but because of these logistics, it is not done to the extent it should be done.
Sure. Neeraj?
So same here, sir. I want to use it in all of my patients, but I don't use it. The simple reason is that there is no ecosystem developed to manage the data that comes in. And sometimes the data that comes in is so overwhelming for a physician to go through and respond to. It becomes a very challenging task. So I don't think industry or hospital are very interested in building up that ecosystem for the patient. It should come from the third party as a separate service sector, develop around this and develops an ecosystem to help all our patients. Then only it is going to be adopted in a regularly in all the patients. Otherwise, there is no doubt it helps us preemptively act on the information that is delivered to us, like increased thoracic impedance, change in the impedance of lead impedance, capture thresholds, and it helps preventing many clinical adverse event that is that if you have not acted preemptively. So no doubt, but yes, the challenges are different and not the clinical and financial.
Yeah, Vanita, you can rightfully have the last word, please.
Is she there? I don't think she's there.
Okay, sure. So I think as Hygreave said, this was a wonderful update on what is contemporary in the CIDs, covering different aspects. CSP, of course, conduction system pacing is the toast of the hour, but there are non-responses to CRT, which I think Suchit discussed well, and remote monitoring uptake hopefully would increase more. And leadless pacing has its niche indications, but needs to be understood in perspective. So all of them, I think, did a wonderful job. I'm sure the postgraduates and some of the early career cardiologists also probably benefited and might move in this direction. We'll close this presentation for today. I think it was helpful. Not before I announce next month, that is 4th August, first Sunday, we will have Dr. Narayan Nambudri's department at Sri Chitra in Trivandrum presenting something unique, and that is about the clinical trials that have been published recently that have changed the way we practice the EP arrhythmia field. So wait for that, and thanks everyone for attending. A big thank you to all the speaker faculty as well as the moderators for taking time out and coming on the program. Thank you very much. Goodbye. Have a nice Sunday. Bye-bye.
Thank you, sir. Thank you so much.
Bye. Yeah.